How and when should MRI be used, and what do they show?
MRI has a very high sensitivity, but it doesn't show the bone very well. So the bone is very important in myeloma, especially myeloma imaging, obviously. So that's the limitation of the MRI. We use it to differentiate between areas of high versus low cellularity. High cellularity meaning most likely myeloma or something else going on there. Low cellularity is usually, especially in the bone marrow, says there's a higher fat content. And fat content is normal. When we grow older, we just have a higher fat content in our bone marrow. So MRI helps to differentiate that, especially if there are fractures. If this fracture is caused by the myeloma or if this fracture is caused by an osteoporosis, for example. There MRI is helpful. MRI has a good sensitivity for any spinal or CNS involvement. So if in the brain, unfortunately, something is growing, that would be a reason. Fortunately, it's very rare, but that's an area where MRI is very good. If there are fractures that kind of go from the spine to the spinal cord, there MRI is very helpful because it shows the spinal cord very well, and we see how a bone fracture can impact the spinal cord. And if there are any neurological issues like numbness or motor issues, that a weakness in a leg or in a limb, then MRI is definitely the choice. Again, depending on what's available. At the moment, the FDG PET-CT gives us the most information in symptomatic disease because a major thing in symptomatic disease is what is left after our treatment, for example, high-dose chemotherapy. We want to know what is left after that, and there PET-CT is at the moment the best choice. So in symptomatic patients, PET-CT before and after treatment is our recommendation. In smoldering patients, we want to see the changes earlier, so the higher sensitivity of the MRI is very helpful. So in smoldering patients, I rather recommend a whole body MRI if available, or at least a spinal and pelvic MRI. So these are the two different areas in our new guidelines, and we have kind of this algorithms what to do when. We recommend low-dose CT because it's fast, it's cheap, and it's available all over the world. So the recommendations were written for the whole world, basically. In the US, I would say, because we recommend low-dose CT there without PET, but it's more or less because a lot of countries just don't have access to PET-CT that often. So in the US, I would say PET-CT is the choice with a good CT, as I mentioned earlier. In other countries where there's no access to PET-CT, at least it should be a low-dose CT. It's kind of this compromise that we recommend there.
So MRI is also a very powerful imaging technique. MRI is great about giving the soft tissue contrast. Essentially, we are tracking water molecules in the tissues, and tumor vasculature changes as the disease progresses. So MRI can give us very powerful information about how the vascularity is changing, how the perfusion within the bone marrow, for example, is changing. And mostly MRI is more effective than the traditional radiographic survey in detecting the changes in the bone marrow and the bone before other techniques can pick up.